really an honor to be able to talk about a topic in pulmonary that has rapidly expanded during the years since he was here. Today, we're going to talk a little bit about the stats on lung cancer. We're going to talk about the history of lung cancer screening and figure out how did we get to lung cancer screening. We're going to talk about what do you do with all those lung nodules you might find along the way. We're going to talk about the importance of smoking cessation that we have at every conversation we have with patients. And we're going to talk about some of the cool technology that we've added at Georgetown with robotic bronchoscopies. Talk to you about a couple cases for it and something called CRATs. So in 2024, there are still 200,000 cases of lung cancer diagnosed in the United States. Congratulations, women, you caught up. We are at 50-50 in the number of cases. And the number of cancer deaths is still huge, 125,000. That number is actually coming down a little bit over the past 10 years. But the truth is that lung cancer is the beast, okay? It is the one that is more than 2.5 times the number of cancer deaths of any other cancer. And yet we don't have me doing the lecture in the first and second year of medical school anymore. This is the one that we need to know the most about because it's the one that kills the most people. This is a common problem, and it is related to smoking. If you recall the first cases back in the 1900s, it was an interesting case to be presented at the pathology course at a university hospital. It was so rare. But then we did what? In the early 1900s, we had a world war. We decided we'd hand out cigarettes to people in the world war and make them calm. And guess what happens approximately 20 years after you start having the war? You start having this huge spike in lung cancer patients who died in males. Why did women not start? Well, we didn't find out it was interesting or sexy to be thin until about the 1960s, when tobacco was advertised directly as a way to lose weight and a way to look cool. And guess what, women? That's where it started, 1960s in women's lib. And here's what happened. Within 20 years, we start seeing the rapid growth of smoking. And now at a point where men and women equal the number of cases, there's still a few more deaths in men than women in the United States. Direct correlation between cigarette smoking and deaths. This is one of those great things about lung cancer. It is the most confusing type of staging there is for non-small cell lung cancer. We're going to focus today on this, which is the early stage 1s and early stage 2s. This is the green section on your non-small cell staging. So people who have no lymph nodes. This includes people whose tumors are less than 1 centimeter, 1 to 2 centimeter, and 2 to 3 centimeters are all T1. That means what? Well, I'm going to show you something about survival and why we titled this talk as Millimeters Matter. Millimeters matter because there is a difference in survival for patients if they have a size less than 1 or a size 1 to 2. If it gets to be 3 to 4 or it gets to be 4 to 5, it again becomes a higher stage cancer. And look at this chart. If you can diagnose somebody who is a stage 1A1, they have a potential cure of 92%. If you listen for the past 30 years for the survival for lung cancer patients, you would hear a number of 15%. And the reason is that we don't see all these early stage cancers up here. We don't get a chance to diagnose them. We don't get to see them until they're usually a stage 3 or 4, where their survival is markedly worse. So if you want surgery to be successful, you need to get it diagnosed early. And unfortunately, everyone else is presenting when they're symptomatic, and that's usually stage 3 or 4. In the United States, only 20% of patients are presenting to us at stage 1, where they would be curable. And that leads us to, why shouldn't we screen these patients? You may say, well, chest x-rays should be a way to pick this up. In the 1970s, 30,000 people were enrolled in studies at Mayo Clinic, Hopkins, and Memorial Sloan Kettering. They used age 45. They used more than a pack a day of smoking, and they did chest x-rays on them at least yearly and the control arm. And then in screen patients, they did x-rays every 4 months, and they did some sputum cytology as well. They did find lung cancers by doing this, but they found no difference between the patients who were screened and the patients who had multiple screens done during the year. There was no significant change in mortality. And that was the final line. If you do not see a difference in mortality in checking chest x-rays, then what have you actually accomplished? The official sentences in that New England Journal article ended with the chest x-ray screening should not be offered to the general population. But they did give you one caveat if you wanted to order a chest x-ray, even though they proved there was no difference in mortality. They left you with a sentence, quote, however, chest x-ray may be of benefit in an individual high-risk patient. That didn't make a whole lot of sense to me. Technology has come a long way. And with technology, we have built out CT scans that can detect things that are very small and before patients become symptomatic. So I'm going to go through some of the historical studies, like how did we get to this and what does that mean for us now in 2024 for screening? The first ones that I can find are literally date back to 1996. This is a group in Japan of smokers. They pay to enroll in this group, and they were allowed as part of the group to go through as many chest x-rays, sputum cytologies, and they could have as many low-dose CT scans of the chest as they wanted to as part of membership in the club. In this group, they did 3,500 CT scans in 20 months on themselves. They turned out that 229, 6% were abnormal, and 19 ended up getting biopsy. And here's where the fun goes. They actually found 16 of the 19 had cancer. One was metastatic. And importantly, they found this, that 14 of those patients with cancer were stage 1 at 93% of those patients. That's way different than we had been seeing everywhere else. Chest x-rays were negative in almost all those patients. And the previous screening, this is a pretty high number in Japan. They had a screening number of 53%. They did remark that at least 3 patients underwent biopsies for what was determined to be benign disease. So there is a cost for looking for this. Interesting in this group, there was no emphasis on smoking cessation. They got reassurance that they had good, healthy lives ahead of them by having a CT scan that did not show cancer in it. So what if you took a CAT scan out to the streets of DC and you just opened the door and you said, come on in, let's get a CT and see if you have lung cancer. Well, that's what they did in Tokyo. This is a curbside CT scan. They took patients 40 to 74. They had them do a chest x-ray and a CT, and they compared it to historical controls. What do you think they'd find just by rolling out the CT in the middle of a city street? And they found out, guess what? 19 of the patients that came in off the street had cancer. Most of these were stage 1. Interesting, 3 came in off the street, had stage 4 cancer just walking around the streets of Tokyo. Only 1 of 19 was seen on a chest x-ray. They did the comparison, and that was a 0.48% rate of detection, which is significant more than what historically was found in the area. Hints that CT screening may be effective at finding early stage cancer and at finding cancer at a higher percentage. So what we really needed was a study to compare and decide if there was a survival benefit of finding these early stage cancers. So in 2011, Georgetown was part of the NLST. This is a study that was powered to determine exactly that. If we find with a CT scan early stage cancers, does this change the mortality overall for the patients screened? The entry criteria are pretty strict, 55 to 74. Anyone want to guess why it was 74? The average age of lung cancer at the time was 74. There's 5-year follow-up in this study. They wanted to make sure everybody was done before age 80 because at that time, many people were felt not to be able to undergo surgery or any other treatment if they were over 80. So they cut off at 74, which, by the way, is missing half of the patients in the United States. So we have to understand 74 was an interesting number. They had to have 30-pack-year history of smoking. Why so much smoking? They needed patients who were the highest risk to determine the benefit, right? If we can't show it in the highest risk, how are we going to show it in people who have smoked less? Active smokers or quit within the past 15 years. They estimated that 7 million US citizens would be eligible based on that strict criteria. They were randomized to a CT chest yearly versus chest x-ray. And as we learned, chest x-ray is a placebo. We haven't found any benefit from that from the earlier studies. So here's the NLST data. And you can see on the top right there, the low-dose CT found more lung cancers. That's one of the things we want to find out. And B, did that change anything mortality-wise? Here is the death rate. And you can see the death rate for those who had CTs done yearly was lower. In fact, it was significantly lower, 20% lower. Let's pause for effect here, because we have to remember breast cancer, prostate screening, and colorectal screening do not have that number. Why are you not screening your patients knowing this data that came out in 2011? International LCAP is a similar study. It's done over a much broader number of patients. It's based out of Henschke's group out of New York, but it goes across the international lines. So with this study, there was a difference. They did a CT every year afterwards and continued to screen these patients every year since. And the result of that actually is, as we expected, probably an even higher benefit of mortality, because they're finding more cancers in the subsequent year, 48% survival benefit. As Dr. Henschke would tell you, if you get a CT detected lung cancer in a subsequent year, you can expect their survival to be 85%. Why? Because you're going to find a subsequent year for this to be an early stage cancer. They didn't have it last year. If they got a new one, there's a good chance we can cure it. In Europe, the Nelson study was also important to know about. This included smokers and did CTs at 0, 1, 3, and 5.5 years. So a little bit wider intervals in this. In this study, they found almost 1% of the patients that were screened had a lung cancer. And they found that majority of them were early stage, confirming what we already knew. And then similar data in Europe, 26% of men were found to have a survival benefit, 26% survival benefit. Here's what we didn't expect, that in women, it was 61%, even higher if we screen women. So in 2024, what is the exact criteria that USPS task force approves for? It's really about what does insurance cover. It covers age 50 and older. So they did give us a benefit of that. They dropped it down by 5 years lower. And that Medicare will pay up to 77. Private insurance pays to age 80. All of us recognize that we missed part of the curve by skipping patients who are up to age 80. FYI, if we determine a cancer in somebody who is over age 80, even if they can't undergo surgery, we can have SBRT with CyberKnife. We have treated more patients in the world than any other site with lung cancer using SBRT with CyberKnife than any other site. So this is a legitimate option, easy to go through. And with the oldest patient I've treated with that is 96. They lived to 101. They did not die of lung cancer. They would have died that year. We had 2 that are that old that did the same thing. So there is an option for older patients. For insurance purposes, 50 and older, 20 pack year history now. We've decided that yes, it's good for 30. We proved it for 30 pack years. We know that people who heavily smoke should be at risk. This is the criteria we don't like. This is the active smoker or quit within the past 15 years. We have a number of people who are aging out of the 15 years. They're getting 16, 17, 18 years out, and they're no longer eligible for insurance to pay for it. That's a problem. So what do you do about all these extra people? What do you do about the patient who's 49 but has a 100 pack year history of smoking and they want to be screened? What do you do about the patient who's over age 80? What do you do if they have 19 pack years instead of 20 pack years? Does that mean they have no benefit of screening? What if they stopped more than 15 years ago? We know that it's the total number of packs that you smoked that put you at risk for developing lung cancer. We know that if you have COPD and emphysema, you smoked a lot and you should probably be at high risk. We know this is a risk factor for lung cancer, but officially it is not enough to be screened with. And then you got to do the next screen, which is, what if your family history of lung cancer, both parents have died of lung cancer and you have had no exposure yourself? We have that question come in. And now the question comes up, what if my parents died of EGFR positive lung cancer and I'm an Asian female never smoker? Well, guess what? That's somebody who's at high risk. There is an ongoing study at NYU right now to take Asians who have a family history and enter them into a screening protocol, because those patients are at risk and they may be at risk at a lot younger age. What if you have HIV positive? You need to start thinking about lung cancer 20 years earlier than the age of the normal person. What about if you have asbestos exposure, uranium, radon? Radon's in the house. You remember when you sell your house, they have to check radon in your basement. That is the second leading cause of lung cancer in the United States. What if they tell you, I have a house that has radon in it? What if I'm a uranium miner? You think that doesn't happen around here, but actually they were trying to open a uranium mine in Southwest Virginia. So these are things that aren't too far away from where we practice. So we know this CT advantages. We know it's non-invasive. We know it's fast. It only takes 20 minutes on a scanner to get through there. It's a single breath hold. There's no pain associated with CT screening. It's completely covered by insurance if you fit the criteria. And we know it increases the detection of early stage lung cancer. It decreases mortality, proven. So what are the disadvantages? Because this is why I think some of you have not ordered a CT from me yet. Failure to detect a central tumor. Well, most of our tumors are on the periphery now. The old days, it used to be get a lot of centrally tumors that are squamous cell. Now it's mostly peripheral adenocarcinomas. What if it's only a 1.5 to 2.6% detection rate? Is that good enough? Do we want to detect a higher rate before you screen them? Let's talk about cost. Let's talk about the radiation. Oh, there's going to be a CT. It's going to have radiation. That's going to cause cancer down the line if I screen these people all the time. What are you going to do with all those lung nodules? You're going to tell me, I don't want to do that. It's a lot of lung nodules we're going to come across. So let's talk about the cost. There are at least 50 million current smokers in the United States, 50 million former smokers. That is 100 million people in the United States at risk. There are at least 8 million that meet criteria for the lung cancer screening as outlined by insurance. That cost is at least, up to 108 billion is what the Outcast estimate was for the first year, and then subsequent years. You have to include the downstream costs, right? Additional CT scans, additional risk of doing a biopsy, et cetera. What are we going to do about radiation? They always say, is it safe to do radiation for these? By the way, all CT scans at Georgetown are all low dose now. So FYI, they're all done the same way. In the average USA person who lives at ground sea level, you get 3 millisieverts of radiation each year. If you live in Denver, it's 10. You go to altitude, you get more radiation. If you have a chest X-ray, it's 0.1 millisieverts to 0.2. And if you have a screening CT, it's 3. It's like living in Denver for 3 months. Is that something that's going to keep you from doing a CT scan? What are you going to do with lung nodules? Lung nodules are a problem. That is why we have pulmonologists, because we have to deal with this. Lung nodules are found frequently on lung cancer screening CTs and as incidental nodules in your emergency room visit. Welcome to the Georgetown emergency room. Let's do a CT scan, right? And then we have to deal with, oh, by the way, there's a couple little spots we found on your CT scan. 24% of the LCAP study, that's New York City, and 69% of Mayo Clinic study had lung nodules. What percentage of those patients who had lung nodules determined to be lung cancer? The answer is 2. That means 98% of the time we find lung nodules, they are benign. And if they're benign, we're going to end up potentially doing more scans. We're going to be doing PET scans. We're going to do some biopsies. And as I showed you in that Japan study, there's a 16% chance in their study that the patients ended up with a biopsy for benign disease. So there are a lot of studies that could end up for this, but we have to deal with the finding the frequent nodules and then deciding which ones are cancer. This is my recommendation for what to do if you have a lung cancer screening CT found nodule. At first, it's a LungRADS-1, which is a totally normal study. That follow-up is next year, get a new CT once a year. LungRADS-2 is anything less than 6 millimeters. 6 millimeters, a tiny little spot. Turns out the chance of that being malignant is very, very low, and you can go ahead and wait for a year before the next CT. If, however, your nodule is 6 to 8 millimeters, it needs to be 6 months. And if you have one that's 8 millimeters or more, you need to be talking to us, because the options here become PET scan, biopsy, or close follow-up at 3 months. So this is where we need to be, is like figuring out what to do with the nodules that are 8 millimeters or bigger. There's some technical aspects with lung cancer screening. You have to have an ACR approved center for screening. We are. You have to have a meaningful encounter. And people think that sending a few moments to decide whether or not it's appropriate to do a lung cancer screening CT, is it worth your time to do it? It does require you to make sure they meet the criteria, which I just gave you, the screening risk of the patient, which means you're going to find some lung nodules. Maybe we're going to have to do some additional testing for it. And it needs to be documented in the EMR so that we can have tracking of this. It's important that we have somebody that can do this for us, including help order the scans. If they're an outside physician, there needs to be documentation. If it's inside Georgetown or inside MedConnect, we can document it in the EMR. Joan is our hero for this. She is running our lung cancer screening program for the past several years, and she's done an outstanding job of getting feedback, not just to you, but to the patient. We send out letters on every scan. That is, whether you are lung rads 1, 2, 3, 4, you're going to get a letter back, and any incidental findings will be reported. I wanted to show you what's been happening at Georgetown for the past 6 years. This is a chart of all the nodules and the results that we had for our screening CT scans. Most of these patients were lung rads 1 and 2, as you can see, which is, by the way, benign type nodules. The ones we worry about are the 3s and 4s, and you can see that we've had a number of those every year. There was a dip in 2020. Anyone remember that thing called COVID? Yeah, the numbers were a little lower that year. Total numbers of cancers in the bottom line. There's 25 patients that we detected with cancer on our lung cancer screening when we have low dose numbers here. We've only got 200 a year. Leahy Clinic's doing 100 a week. 100 a week. You guys ready for that? It's going to be the detection rate that's going to be important. Our detection rate is 2%. Give us some more patients, watch what happens. 2% of patients who mostly are savvy that we exist out there in lung cancer screening world. There are ways to try and figure out how to get people out there. We should know the following, though. 61% of Georgetown patients have lung nodules. That's closer than Mayo Clinic than it is to New York City. Histoplasmosis being the number one thing, we are seeing plenty of it here. We'll see lots of benign nodules. We have to weed through that to find the ones that are cancer. 89% of our lung rads are 2, which are the ones that are benign. So most of these are tiny, we don't need to do much about, but it's those 3s and 4s that we have to do something about. We find lots of patients who have emphysema along the way. We see lots of patients with coronary artery calcifications. These are things you may want to think about as their risk for heart disease goes along with their history of smoking. And we've also had patients showed up with mediastinal lymphadenopathy, a couple of patients with sarcoidosis as a result. So other institutions that reported interstitial lung disease, and because you're doing the chest, sometimes we see breast nodules in there as well. So let's talk about screening. It is an opportunity for smoking cessation. You should be considering that probably every time your patient comes in and they answer with cigarette smoking, yes. This is a chance when we're doing lung cancer screening for us to take a moment and say, are you still smoking? It's time to stop that habit. My team in the back who's saying, yeah, Eric's great. When they come in, they're still smoking and they're in the lung cancer clinic already. We're going to have to sit back and wait for him to give a lecture. That's the way it works. We got to be hard on them, but we have to realize it's for their benefit that we're doing it. Quitting between the age of 55 and 64 is actually beneficial to people. So let me get that back for you. Gives you 4 extra years of life if you screen these people, FYI. So if you have 5 A's when you see the patient, A is ask when they come in, are you smoking? Advise them, you know, that's probably not a good thing to do. You should probably quit. You should assess them. You ready to quit? My office, I don't really assess them. I just tell them. Assist, that means we're actually going to help. You can't just say, hey, you got a smoking problem. You need to say, hey, I have something we can do to help you. Let's do Chantix. Let's do Wellbutrin. Let's do nicotine. And let's bring in 1-800-QUIT line. And make sure they're followed up with afterwards. Counseling with medications is proven to be better than just medications alone. 1-800-QUIT now is a way to get free support. It is telephone support. They'll call the patient. They'll talk them off the edge. They will give free discounted medicines if needed. And they also give them back a whole bunch of other things. These are my other two heroes that I have in my group that you probably haven't heard about, but Catherine Taylor and Randy Williams are part of Lombardi Cancer Center. We spent a lot of time doing smoking cessation with lung cancer screening as a tool to try to get people to stop. These people you should thank. We have been working for the past 2 years to help out with your EMR. We are making things happen for you right now, internal medicine family practice. You've already got it. We have created a process where the MA does vital signs and the MA asks your smoking history and the MA asks it correctly and the MA enters it correctly because we know physicians don't ask. Number one person who doesn't ask about smoking, the physician. They want to deal with the upper respiratory tract infection. They want to track whatever the problem is, broken leg. They're not asking about the cigarette smoking. The MA is now doing it for you automatically. They all do it across MedStar, which is a cute thing. This is going to trigger two important things automatically. Electronically, once they hit yes for smoking, they're going to get a referral to the 1-800-QUIT line. And B, they're automatically going to get a trigger that sends it to you saying they qualify for lung cancer screening. We'll do the calculations for you. All you have to do is click yes and order the scan. In addition, yes, you can thank us for this one too. It came out last week. This is part of your ambulatory summary and education pack. This is an up-to-date smoking cessation information and includes some things like the MedStar Health Counseling Program. There's a line that we can use for that. It includes the 1-800-QUIT line. It includes a text messaging program. It includes an app that they can use on their thing. All these things to try to help you get them to stop smoking. And in the small print, a nice little printout of things that get better in the timeline, they get better. Like your cough gets better, your risk for heart disease gets better, your risk for these cancers reduces over time. These are all helpful things that you're now going to get, hopefully print out automatically when you put down their diagnosis as smoking or lung or tobacco use. So what are we going to do about the biopsies? You got a lot of nodules and now you got to send them over to us. How are we going to get there? In the past, you're like, oh, just do a CT-guided biopsy. Last year, Georgetown did 2 CT-guided lung biopsies the entire year. Do you know why? And who ordered the last 2? Me. That means we ordered them because we didn't get it. That means our referral thing is working. We're going through the less chance of causing harm to the patient by sending him for bronchoscopy instead of going for a CT-guided biopsy. Now we have the technology to get there. Georgetown was #1 in getting a robot bronchoscope here. The reason for bronchoscopy being limited in the past was that the scope gets down into the smaller airways and it can't go any further. It's too big. We needed a way to get out to the periphery. And we know that biopsies out here in the periphery blindly or just with fluoro are hard to do, hard to be accurate. We know that biopsies in the periphery have a low yield, very low yield. Who wants to biopsy something at 31% central, 14% peripheral biopsy when we know that CT guidance can get 90%? We'd had Super D here for a while, navigation bronchoscopy. In the best of hands, 69% of peripheral lesions. I want you to pay attention to this. Average size in the literature, 3.35 centimeter nodules. Those masses, by the way, are pretty big for somebody to be biopsying them. That makes the yield not so impressive, but we do know that it's safer than biopsy by CT guidance, less than 2% pneumothorax rate by doing biopsies from the inside of the airways. We did find out things that made a perfect target. If it's a peripheral nodule and it has this, an air bronchus sign going straight at the target, that's a high chance of us getting to the thing. There were some limitations though. What about these really small nodules? One's out in the periphery where the airway seems to divide on either side of it, or there's no airway anywhere near the target. How do you get to that? What if it's going out to it, but it starts branching away from the target? You know your tools are going to bend off of that. Welcome to robotic bronchoscopy. We are the first to own a robot bronchoscope, and just FYI, there are now 400 in the United States. So many hospitals are tagging on to us to see how we do. There are 3 manufacturers, and I'm going to tell you about the Ion today because that's what we have, and that's the one I feel is the superior technology. There is some planning software that we need to do. So yesterday we were planning bronchoscopies for tomorrow. It needs to have a high resolution CT scan. All CTs done at Georgetown now include robotic protocol as part of it. There's no extra energy involved with this. High resolution CT done at 0.8 millimeter cuts are done as a computer reformulation of the CTs being done. We create a bronchial tree and the computer helps us select the best pathways to get to the surface to get to the target and to avoid hitting the pleural surface. And just to show you what the technology starts looking like, but we get a recreation of the 3D tree of the actual patient. That little blue or green spot is the target way the apex of the left upper lobe. So we can move that around to see where we're going. This is what it looks like when we actually do the airway exam. So you can drive down with our virtual pathways and you can watch the path of where we need to go. And yes, we can go all the way out to there and be able to see it the whole way. Very cool technology. So there are some advantages. This catheter that we use is very small. However, the working channel is the same size as our traditional bronchoscope, which means we can get way out there and use our tools to biopsy things that are out there. It's very flexible. The needles go through it are flexible. It has something called shape sensing, which means it can tell me where I am the whole time because it's got sensors all the way along it. That's different than the other technologies that are out there that only have a sensor on the very tip of the bronchoscope. This allows one other important thing. Once we are shaped in the direction we're going, we now do a CT-guided kind of biopsy directly at it. So we take a needle and cut through the tissue directly at the target. Now it's like a CT-guided biopsy from the inside. And we know the difference, 25% pneumothorax, 1 or 2%. It's actually 3 or 4% because we're now biopsying things that are right on the pleural surface. So it is a lot safer to do it by bronchoscopy. We have to combine this with other technology to really make this accurate. One is called a radioprobe endobronchial ultrasound, a tiny little ultrasound that fits through the robot. And if we've done it right, this is what it looks like, an ultrasound of the nodule, and in the center is our probe. If we are in the middle of the target, there is a very high chance of us getting a diagnosis. During the robot bronchoscopy, we get feedback in a lot of different ways on our displays. One of my favorite is the subway view. This is the pathway we're supposed to go down. And if we make a wrong turn, everyone in the room notices that I made a wrong turn before I do, right? Because they see this thing going the wrong way. They, whoa, you went the wrong way. And then we back up and we follow the correct pathway down. This extra technology includes how far it is to the front edge of the target, the back edge of the target, and our needles can only strike as far as we want them to, so we can set it to biopsy the distance we need to. Tells us how far to the pleural surface. We don't want to hit that. And it does fluoroscopy. It does a virtual pathway indicator, and it's actually got a radio ultrasound in there. And somebody named Gus who actually tells us which direction to point when we need to make corrections. This is the other technology that's available. This is using a fluoro spin. In the bronchoscopy suite, we've gone from low tech to high tech. We now have to have a 3D spin, goes around the patient and creates a CT scan while we're in the bronch suite. So once we have our needle in the target, we can then have it spin and we can figure out how close we were. And if we're off, we can change it. Here's one I did the other day. This is the robot catheter through the patient. Here's the tip of the catheter. Here is our ultrasound sticking into the nodule. The nodule, as you know, is way out in the periphery. This is the other way it's cut. And you can see in the coronals here that the target, the actual catheter is in the middle of this. Now, if you look at this shape very carefully, here's our radial ultrasound. Now, if you flip this upside down, that is exactly the same shape as here. So now we are at the point where we can get right onto a target with the technology. So there's some really neat advantages here. We can stay fixed at a target. It does not have to have tools branching off where the airways go. The old days when we had Super D, the catheters would be shaped this looks perfect. Here's the target over here. But when we put it through a flexible catheter, it starts trying to biopsy out here. Didn't work. This is going to be similar to CT-guided biopsy from the inside. We know the yield should be similar as a CT-guided biopsy, and the risk of pneumothorax is low. So let's give you an example. It's Grand Rounds, 63-year-old former smoker, underwent lung cancer screening, had a CT found, and got this. Now you guys are like, is there a nodule there? There it is. 7-millimeter nodule. Got that little thing? It's smaller than a pea. The PET scan had a little bit of activity for that little small thing. SUV greater than 4 is often cancer. So here's the robot plan. You can see us, we drove down through the airways. We got all the way without making a wrong turn. We got to within the radial showing the target, and we're very close, only 6 millimeters away on this picture. Anyone remember what this is? This is your keratinizing pearl from squamous cell carcinoma. Needles, brush biopsies all showed cancer. The nodes, we do EBUS to stage everybody in the mediastinum. The CT guys can't do that, so they always have to send to us anyway. Robotic surgery removed this, and it was a T1A-N0. That is a stage 1A1. Anybody remember that first complicated staging chart and the survival? Yeah, 90% survival. We got that nodule at 90%, not 15, not the overall number that people are hearing now, 20% survival for all patients. You can get them early, you can get a diagnosis and a cure. These are some of our preliminary numbers on the first 200 patients. You can see for size less than 1 centimeter, 76% for something less than 1 centimeter. For 1 to 2, 82%. For 2 to 3 centimeters, we're at 97%. Isn't that interesting? Add the seat. This is without the cone beam fluoro spin that we're talking about. This is just with us, with the robot plus radio and fluoro. You add the 3D spin, we're going to be pushing closer to 95% across the board, it looks like. Overall yield, 86%. Let's step to the next step. What are you going to do for these patients? You've heard of VATS. You've heard of RATS. Everything is robotic assisted thoracic surgery. Yes, we did have a naming team get together for this, and the committee has come up with the following CRATS, combined robotic assisted thoracic surgery. The same procedure. We did it this morning. We're down in the OR. We did robotic bronchoscopy first, and then the surgeon went and did surgical resection at the same anesthesia event. What that means is that we do bronchoscopy, we do EBUS, we stage the mediastinum, and we stage the opposite side the surgeons can't get to. We biopsy the target to see if it's cancer before the surgeon does. We put ICG dye marking. This is a fascinating. You inject fluorescent dye into the target, and the surgeon can switch the robotic assisted thoracic surgery Da Vinci onto black and white, and on black and white mode, the ICG dye is fluorescent green. Here he is stapling across here, and you can see he's taking out the part that we marked, and you can see that he's taken it out entirely where the target was. This is especially helpful for the surgeons. They cannot feel tiny spots, and we're trying to get the tiny spots. They can't feel the ground glass nodules, and we want to get those before they turn into an aggressive one. And the surgeon takes it out with either a segmentectomy or a lobectomy. In our first 44 we did in the first year and a half, we're up to about 80 cases right now. The patients that we did all were able to successfully undergo the procedure as a single anesthesia, and we did sampling of lymph nodes. We are highly selective. If the patient has PET positive mediastinal nodes, we do not offer them CRATs. We offer them bronchoscopy to figure out the nodes first, because that would change the order of how we treat them. We have pathology as expected. Most were lung cancer. Some were some strange cancer, including a small cell, and oligometastatic disease, and then a few of the stranger ones in there. But majority of the patients, they had surgery, and that's all they needed. There were a number of patients you saw that were either stepped up because they had a solitary nodule with a satellite nodule, or they had lymph nodes that also had to have systemic therapy. This is where you start paying attention. Okay, 51-year-old female smoker. She came to see me because she had a new CT scan to follow up on a nodule she'd had previously. The nodule got bigger. This is Monday. She got the CT. She sees me right after the CT. I called down the surgeon. Dr. Margolis, of course, comes whenever called. Ran down and said, "Hi, I'll see the patient with you." Tuesday, we did a PET scan. Yes, I must have bribed Dr. Esposito to get the PET scan that day, but we got it on Tuesday. Thursday, we got a CRATS. That means EBUS staged normal lymph nodes, transbronchial biopsies, adenocarcinoma, ICG dye marked. Because it's less than 2 centimeters, the patient had a segmentectomy, which is as effective as a lobectomy for size less than 2 centimeters. The patient was discharged on Monday. That's 1 week. Do you know what that does for your lung cancer? It prevented it from growing. And when you talk about the difference between millimeters matter, the time that we see for people coming to us for second opinions can be up to 2 months by the time they get to us in Lombardy. So they've gone to the pulmonologist, they've gone to the surgeon, they've gone to the radiation oncologist, they've gone back to medical oncologist. They get to us, and the first thing we have to say to them, we need a new CT scan. Okay, if we can do this every time, you're talking about taking 7 days to get the surgery to cure you. That prevents that chance of it growing and getting bigger. Okay, so can we do this in everybody? This is our goal. This is our standard, what we'd like to have. Not saying that we can do it in everybody, but we'd love to be there. Robotic bronchoscopy is adding other applications. I showed you how accurate that needle can be. So you start thinking about what else could we do by putting catheters, APC, RFA, microwave cryoprobes through the bronchoscope directly into the target and see if we could destroy them. We have a competitor in the audience. Dr. Podell really knows that the beast out there for treating cancer is something called SBRT with CyberKnife. And that local control is 90%. In order for us to show a benefit of any local therapies inside the airways, we have to beat 90% local control. RFA done by CT guided biopsy has a 40% local control. So we have to make sure that we do better than what we would have for SBRT. So where will we go with that? Waiting to see, but those are the next applications that we'll be using. This is your pathway of what we'd like to see. You have patients that are either getting a low-dose CT scan or they're getting a CT done by you for other reasons. They get referred to us, and we're either thinking about, is this a solitary nodule that can be resected in a single anesthesia event by Kratz, or are we going to have lymph nodes evaluated, biopsied, and potentially putting fiducials in and tracking them for SBRT with CyberKnife? We'd like to do that within the week. That's the goal. Technology is important, but it's also hard to get scheduling between all the different parts in the puzzle, but it does happen sometimes the right way. So I put you up as a title of Millimeters Matter. I think you need to know that lung cancer survival has improved dramatically in the past few years, partly because of immunotherapy, partly because of targeted therapy. Our medical oncologists have done an outstanding job of getting better drugs that treat the disease. We can help. We can help by doing detection when it's early stage. If you detect it before it spreads, you're offering your patient the better chance at survival. It starts with CT screening. If you haven't ordered a CT scan on one of your patients, and I know who you are because I see them all, there are a lot of you who haven't done it. I'd love to know why. I showed you the reasons why, and I showed you the answers why you should anyway. We do know that robotic bronchoscopy is getting to these smaller nodules. We can give you a diagnosis now when the things are small. That's pretty cool. We also know that there's a way to do a shortened time from the CT scan to the time of treatment. And that starts with a thing called Kratz. So what do you do once you've gotten your cancer diagnosed? That's another important thing. You come to this. These are the big pillars that help keep us running. This is the combination that makes it work. We have now this year, year number 25 of the thoracic oncology clinic that we set up in 1999. And it's 25 years that everybody's contributed to making it happen. For those who don't know, every Wednesday afternoon, every patient who's a new diagnosis or has stage 2 or 3 that's complicated, needs everybody's input on it, can come and be seen by all of us at one clinic time. And no, it's not just, I'm only going to see this one or that one. Literally yesterday, it was thoracic surgery, medical oncology, radiation medicine, and interventional pulmonary in the same room, talking to the patient at the same time. Now, if you've ever sat on the other side of that table, you would understand that speeds things up. You have everybody talking about the order of what you're going to do, how you're going to do it, and answer all the questions about it. And this is the way it works the best. There's tumor board that's going on the same day, but you have the baseline of this is a clinic where it all works out. In addition, on Thursdays, we have the CyberKnife Lung Clinic, which is patients who have either had CyberKnife or proton therapy or want to be evaluated for those treatments. And that's radiation medicine with Dr. Podell and I and Rebecca, seeing patients who want to be treated with those modalities for their cancers. So if you've learned nothing else today, you've learned this. There is no longer a reason to do a CT-guided biopsy. There's too high risk of pneumothorax for patients, and we now are approaching the same diagnostic yield by doing it by bronchoscopy, and at the same time, we're staging the mediastinum with tissue to confirm that the lymph nodes are normal. We all need to be involved in this, which is making sure that we do everything we can to stop the cause. The cause is cigarettes, and we got to do whatever we can to talk to our patients about it, make sure that we give them some resources to help them. And we have added some new features in the EMR, which should help you automatically start doing this, okay? And as you know, some quitters are winners. I'd be happy to take any questions that you guys have for me about lung cancer screening or about the future of interventional pulmonary techniques of biopsying things.